I can think back of how tough it was and how it's come to this point and understand that moving forward, things are only going to get better because newer drugs are being developed that will help maintain this. I'm still here.
Welcome back to another episode of The Blood Cancer Experience, a podcast by the Leukemia and Lymphoma Society of Canada. I'm your host, Christina Clark. Today, we're focusing on multiple myeloma, a type of blood cancer that affects the bone marrow. It's a challenging disease, but one where research has made a lot of progress in recent years. To give you an idea, about 4,100 Canadians are diagnosed with multiple myeloma in a year. In 2024, an estimated 15,000 Canadians are living with or in remission from this disease. In today's episode, we'll be hearing from David Johnson, who has lived with multiple myeloma for over 12 years, as well as Dr. Anthony Reiman, an oncologist who focuses on the diagnosis and treatment of this type of blood cancer. David's story is one of resilience, from grappling with a diagnosis that changed everything to finding purpose in helping others. Before his diagnosis, David ran a successful business in the property improvement industry in British Columbia and led an active life with his wife and 2 children. But in 2008, his business partner fell ill, and David decided to transition into a new career.
I had a couple of passions, one being photography.
He spent many years taking school and sports portraits, a job that kept him constantly on the move. In the months leading up to his diagnosis, now in his early 50s, David brushed off some significant warning signs. Back pain was a frequent issue, but like many of us, he chalked it up to everyday strains. That all changed in 2012. One day in May, while working at a school photo shoot, David attempted to lift a ladder and felt a snap in his ribs. Weeks later, he stepped off a curb carrying photography equipment and collapsed. What he thought was merely bad back pain turned out to be something far more serious.
My back would go out constantly. And, I'd go to the doctor and he would make me do some exercises, bend backwards to see my range of motion and always indicate that it's a back problem. You've probably, hurt some, strained some muscles. So just rub some A535 on it and, it'll pass. So there were signs that something was going on. I just don't think that they were pursued enough.
After enduring 3 months of debilitating back pain that left him confined to bed, David was taken to the hospital, where a CT scan revealed his bones had deteriorated to the point of collapse.
I got to the hospital and was admitted. They took me down for an x-ray, and when I got back to my room, I had a visitation from the, I don't know if it's a triage doctor, but one of the doctors in the emerge, and he said, "Have you fallen off a ladder recently or something has happened recently? Because you've broken your back." I had no idea, and I had said it to him, I just simply stepped off a curb, and then I had back problem. So he said, "Well, I think we better get you into a CT scan to have a look at it a little more closely." When they did the CT scan, that's when they found the lytic lesions, which are typical of multiple myeloma, where the proteins actually will eat through the bone and cause lesions in the bone, holes basically.
Dr. Reiman is here to shed light on how multiple myeloma is diagnosed and the treatment options available to those who are affected by it.
Multiple myeloma is a bone marrow cancer. So the bone marrow is the spongy inner part of our bones. Most of our larger bones have marrow in them. This is where our blood is made. And in the case of multiple myeloma, there are cancer cells in the bone marrow, crowding out the healthy bone marrow, preventing it from effectively making blood as well as it should. These cancer cells can start eroding into the structural part of the bone, the harder outer shell of the bones called the cortex, and the bones can become prone to fracture or pain. So patients often present to their doctor complaining about fatigue, back pain, maybe shortness of breath. and some basic blood tests might be done, which might show that the blood counts are low or the kidney function is off, or maybe the calcium is high, and this usually prompts a fairly quick response by the medical team to try and figure out what's going on. This is one of the challenges of myeloma. It doesn't necessarily jump out at either the patient or even the healthcare provider at first as the diagnosis.
Once diagnosed, David immediately began intensive treatment. The first step was a round of high-dose chemotherapy in order to reduce the cancer cells in his bone marrow. The next step was a stem cell transplant, using healthy stem cells from David's body to replace the ones in the bone marrow destroyed by the chemotherapy.
But the result of all of that is that they almost immediately started me on the program that I would be on, because I was pretty far along. I'd lost a lot of weight. I usually was around 235 pounds, but I'd gone down to about 173 pounds and couldn't shower myself, couldn't barely dress myself. And so that was a tough time. Tough time for my family, tough time for my wife, and really depressing time also. But, once things start moving, you start to get a little hope and you start to figure that you're going to be okay.
David was sent to the Vancouver General Hospital to see an oncologist specializing in blood cancers, who would evaluate his symptoms and guide him through the next steps.
He had a lot of insight to it and reassured the whole family, because we all went together for that first meeting, my kids and my wife, and reassured me that this was a manageable disease and that we were going to get going on it and we were going to start treatments and everything, with the intent of having a stem cell transplant 4 months down the road. I had to go through 4 months of chemotherapy to get my light chains, which are the proteins that cause the problem in the first place, down enough to make it easier for the stem cell transplant to take. I also was put on a bone hardening drug to try and shore up some of the problems in my bones, reminiscent of osteoporosis, for example.
The main treatment for myeloma is some type of therapy that can get through the whole body to try to seek out these myeloma cells and suppress them or destroy them. Historically, we used things like chemotherapy as the primary treatment for myeloma. So it's actually pioneered by a Canadian myeloma doctor several decades ago. We didn't really find anything that worked a whole lot better than what he had come up with in the early 1970s or so for 20 or 30 years. And then we realized that if you could give high doses of the same chemotherapy drug that he was giving, that it would work better. We're trying to wipe out these cancer cells from your bone marrow, but it'll wipe out your healthy bone marrow too. And so people basically need a type of bone marrow transplant to get through that. And these days we usually do a type of bone marrow transplant where the patient is his or her own donor, collecting what are called blood stem cells from the patient themselves, putting them in the freezer, and then thawing those out and giving them back to the patient after they've received chemotherapy. And these blood stem cells have the ability to find their way to the bone marrow and reconstitute the blood production that is lost. This form of bone marrow transplant is known as an autologous stem cell transplant, and it's aggressive treatment. Patients can get sick from high-dose chemotherapy or complications of the transplant. So not every myeloma patient is eligible for that, but for patients who are fit enough to undertake such a procedure, that's still felt to be the best treatment, is to incorporate high-dose chemotherapy and autologous stem cell transplant as part of the treatment.
David's treatment was successful, and he entered remission. For 5 years, life returned to something close to normal. But in 2017, the cancer returned. Genetic testing revealed that David had a low-risk subtype of myeloma, which responded well to treatment, but required another round of chemotherapy and a second stem cell transplant.
Most stem cell transplants last anywhere between 2 to 5 years. Now, at that time, there was a new genetic test that had just come out, and so they took some more blood and marrow from my hip and ran tests on it. The good news was that I was missing a particular gene that made my multiple myeloma a lot more manageable than it would be if I had that gene. Low risk myeloma, that's what I call it. There are doctors, I've met with one that said basically it's you can call it low risk, but really it's just normal myeloma. There are some that are a lot more virulent if you have that gene. So we got me prepared again. So 4 months of chemotherapy again. And then another stem cell transplant took place. That one was a lot tougher when I was first diagnosed. The amount of chemotherapy to get rid of all of the bad light chains and proteins in the bone marrow was based on my weight of 173 pounds. Well, by the time I hit my 5 years and came out of remission, I was now 230 pounds. And so the chemotherapy amount had to go up dramatically. And so I had no problem being at home my first stem cell transplant. And in fact, didn't really find it all that tough from the chemo point of view. But the second one, because it was such a huge amount of chemo in comparison, I didn't last a night. I ended up calling a friend who then drove me to VGH, where I spent, I think it was a week in VGH, recuperating from an unbelievable reaction to the chemotherapy. But I made it through it, and I'm here to attest to the fact that it worked so far. Yeah. You just have to do what you have to do.
Most of the time, patients are unfortunately going to relapse at some point, regardless of what treatment we give them. We're always hoping that the newer treatments are going to change that. And there certainly are patients who've had stem cell transplants who have lived for many years without relapsing, but we're always just thinking, well, eventually they're going to relapse. The possible exception to that historically has been having a bone marrow transplant where somebody else is the donor, which is really something that's more challenging, a little riskier than using yourself as the donor for your transplant, but which offers the opportunity for your donor's immune system to fight your cancer. And we think that maybe some patients never relapse, or maybe that they're actually cured by that treatment. The risk and the side effects of that makes it a treatment that's only really feasible for a smaller group of myeloma patients. And sometimes if a previous treatment has worked really well, we can give it again. So patients can have an autologous transplant more than once. But we typically only do that if it's worked really well the first time, because it's a hard thing to go through multiple times. Some patients will actually have 2 rounds of high-dose chemotherapy and 2 transplants back-to-back to try to get the deepest possible remission, but that's also kind of reserved for the fittest patients, perhaps with the highest risk disease.
In 2022, David faced his second relapse. This time, his treatment involved a clinical trial for T-cell therapy, an emerging immunotherapy designed to harness the body's immune system to fight cancer.
The second stem cell transplant lasted until November 2 years ago. And so I came out of remission again, which was almost 5 years. So that went basically the same as the last or the previous stem cell transplant. But at that time, because you've had 2 stem cell transplants, a lot of chemotherapy, the chances of getting stem cells, baby cells out of you is pretty slim. So I was offered by my oncologist. She was running or heading a clinical trial out of the US for T-cell immunotherapy. And so there was one spot left that I had to make a really quick decision on. She gave me basically the weekend to decide. And the Monday I had to make a decision, so I decided to go ahead with it. I went on this clinical trial, which is an A and a B group. It's basically a spin of the wheel, so you never know whether you're going to be on. It's not like they put you on a particular group. They just spin a wheel, and that's the group you're in. And I ended up in the B group, which is what they call better than standard care. So I take a chemotherapy pill, 21 days on, 1 week off. And at the end of each cycle, I go in to get my next round of chemotherapy pills and an injection into my stomach that also is part of the protocol. The A group would end up with the T-cell immunotherapy, which is going to be the next big thing in blood cancers, and in fact, other cancers also. Pretty heady stuff, but it's going to be the next big thing.
Well, it's certainly true that the development of new therapies over time has improved outcomes for patients. So the average lifespan for patients who were treated with the original regimen was 2 or 3 years. Adding high-dose chemotherapy improved things to about 5 years average survival. Incorporating some of these drugs developed at the turn of the millennium And adding those to a transplant for patients who are fit to undergo one has increased survival to somewhere on the order of 7 to 10 years on average for patients who can receive all that therapy. We're still learning about how these T-cell redirecting therapies like CAR T-cell therapies or so-called bispecific T-cell engager therapies, what the long-term impact on survival is going to be for those. But we know that for patients who have multiply relapsed disease, who've had all the prior therapies and then turn to these newer therapies, that they can survive for many months, for a few years. I think our focus right now is on figuring out how to incorporate those promising immunotherapies maybe earlier in the timeline so that patients can get more benefit from them. And maybe that will translate into the best long-term outcome with these therapies. A lot of the work right now is going into making immune therapies better. So the next generation of CAR T cells or different types of immune cell therapy or other types of immunotherapy seem to be where the big ideas are right now.
Over the last decade, David discovered meaningful ways to share his experience and build connections with others facing similar challenges through the Leukemia and Lymphoma Society of Canada's First Connection peer support program. He is also a blood cancer ambassador, offering support and raising awareness about the unique needs of the blood cancer community, and providing feedback on how to improve the patient experience. By offering guidance, sharing his story, and providing emotional support, David helps others navigate the complexities of living with blood cancer. I'm curious, what motivated you to become a volunteer for the First Connection peer support program, and how has that shed light on your own experience?
Actually, it's really helped my own experience, and it helps me in the sense that I'm able to give back. I went through a lot to get where I've gotten to, so if I can be of help to anybody who has recently been diagnosed with a similar blood cancer, then why wouldn't I? And so the way the program works is I get a phone call indicating or an email indicating that there is a patient in Toronto or in Manitoba or wherever across Canada that has been recently diagnosed with either multiple myeloma or something of the same bent. And would I mind touching bases with them because they want to talk to somebody? And so that's what I do. We hook up over the phone and I answer any of their questions, and they can look at me as a resource for somebody who has made it through 12 years of having this, what used to be a unmanageable disease. I'm an example of what can be done with a person who ends up with this form of blood cancer.
In Canada, we're blessed. We've got a really good healthcare system, despite the stress and strain that the healthcare system seems to be under. And in particular, we've got a lot of expertise across the country, some really world-class myeloma healthcare providers, researchers, and patient organizations that support myeloma patients and their families. And so we're not alone, and there's a concerted effort in Canada to try and do our best to help. It is a treatable condition. It certainly is a life-changing diagnosis and challenging to live with myeloma, but there's certainly prospects for hope, and Mr. Johnson is a good example of that.
David's experience coming in and out of remission reflects the realities of treating multiple myeloma, but it also highlights the positive advancements in research and treatments. I'd like to extend a sincere thank you to David for sharing his remarkable story, and to Dr. Reiman for offering his expert insights and shedding light on this complex disease. For more information about multiple myeloma or any blood cancer, as well as the free support and services offered by the Leukemia and Lymphoma Society of Canada, please visit bloodcancers.ca. Thank you so much for listening. This podcast was possible with support from Johnson & Johnson. Thank you for your contribution to helping us understand the blood cancer experience.